So we have to start on time. It's 20 minutes to 5 o'clock in the afternoon. And we have, in the organizing committee, selected some presenters from their posters. So anyone who haven't been out in the poster area, please go out and have a look. They're really great, all the posters out there. So the first we're going to hear is the elevated soluble CD163 at baseline and increased PD-1 expression and CD8 positive T lymphocytes are associated with poor outcome in metastatic renal cell carcinoma by Mia Christensen, and it was really difficult to read that up.
Well, thank you for the organizing committee for allowing me to present today. One question the patient often asks is, what is my prognosis? In the clinic, we use the IMDC score to help us answer this question and to guide us in treatment selection. However, the IMDC groups are often broad and further markers are needed as an add-on to this system. In a cohort of 89 patients receiving IL-2 and interferon, blood samples were collected and analyzed for soluble CD163 and PD-1 expression levels on lymphocytes. Tumor-associated macrophages are associated with worse outcome in several cancers, especially the expression of the scavenger receptor CD163. CD163 also exists as a soluble form in the blood, and our group has found that elevated baseline soluble CD163 is associated with a worse overall survival in metastatic renal cell carcinoma. Expression of the checkpoint molecule PD-1 is only present on activated lymphocytes, and the expression increases when lymphocytes become exhausted and lose effector functions. Furthermore, cancer cells use the PD-1 and PD-L1 axis to avoid lymphocyte-mediated killing. Patients where PD-1 expression levels on CD8 positive T cells was increased had worse overall survival. We used these two markers to divide patients into 3 groups based on whether they had none, 1, or 2 of these markers present. And we found significant differences between the 3 groups, with the group with 2 points having the worst overall survival. Validation is needed in a larger cohort, receiving current first-line treatments such as IO, and this is planned as a part of the Nordic Sun trial. I hope to see you later by the posters.
Thank you, Mia. That was a great presentation and on time. Thank you so much. The next speaker is Lisa Kinten, who will speak about multi-omics and special architecture of antigenic macrophage CD8 cell crosstalk at core of immune checkpoint response in advanced clear cell renal cell carcinoma. Please.
Thank you. So hello everyone, my name is Lisa Kinhet. I'm from the University Hospitals of Leuven in Belgium, and I would like to thank the committee to give me the opportunity to advertise my poster here today. So it has been said many times today that we urgently need better biomarkers for immune checkpoint inhibitors in renal cell carcinoma. And not only do we need biomarkers, we need to better understand what drives response to immune checkpoint inhibitors in RCC so that we can better design novel combinations of immunotherapies. And these questions inspired our study, where we looked at a real-world cohort in our center of immune checkpoint inhibitor-treated RCC patients. And we performed several in-depth multi-omic biomarker analysis, which revealed that patients who had an HLA genotype that preferentially presents neoantigens were doing better on immune checkpoint inhibitors. And because we wanted to cross-connect this to the tumor, we used a machine learning model to cross-connect the HLA genotype to tumor transcriptomics. And this novel gene signature that we developed this way correlated response not just in our cohort, but also in a lot of publicly available RCC cohorts spanning over 1,000 patients. And next, we were wondering where is the biology behind our gene signature, and for this, we looked at single cell and spatial transcriptomics, and also at spatial proteomics. And here we found that antigenic macrophage and CD8 T cell interactions were at the core of our signature and also at response to immune checkpoint inhibitors. And then finally, to functionally validate this, we tested several combinations of immunotherapy in a mouse model of RCC. And here we saw that a combination that activates both CD8 T cells as well as macrophages was performing the best among the therapies that we tested. So if you want to learn more about my research, which was recently accepted in Nature Medicine, please come find me at my poster and I will tell you all about it.
Thank you. And now Dr. Toneman will tell us about patient-derived kidney cancer organoids in predict patient therapeutic responses. Please.
Brilliant. Thank you. Thanks to the committee for giving me the opportunity to talk today. So I am a final year PhD student in the KSP lab, or the Croche-Parsi laboratory, where we're able to work on patient-derived 3D culture systems and humanized mice in order to tell what is the next best direction for novel therapeutics. But the first major obstruction to this work was that kidney cancer largely struggles to grow in vitro despite growing quite well within people. And the major question derived from that is, why would it grow well in a person and not well in a dish? And this, from what I could best tell when I started the PhD, was on the basis of the absence of niche factors included in classic culture formulations. So we exercised our studio tools like NicheNet and found a number of growth factors affiliated especially with clear cell RCC. And I tested these through an organoid formation assay involving organoid culture conditions and kinetic tests in order to find out what is the optimum growth factor formulation for clear cell RCC. This has enabled me to perform a co-culture system with autologous T cells for the testing of a novel immunotherapeutic combination, including relatlimab. And this further has enabled me to tell what is the possible future direction for clear cell RCC culturing, which I'd be happy to talk about later. Hopefully I will see you soon at the poster, and I'm happy to discuss any of these points further. Thank you.
Thank you so much. Now, Dr. Monar Boutou, is that right? Okay. He will tell us about renal cell carcinoma treated in first line with immunotherapy-based therapy. Please.
Thanks to the scientific committee for the opportunity to present our study. As you know, bone metastasis is a poor prognostic factor in renal clear cell carcinoma. Location and number of bone metastases are prognostic factor, but no data are available at the immunotherapy area. That's why we included all patients treated in the Strasbourg Cancer Institute with renal cell carcinoma and bone metastasis, treated with, in first line with immunotherapy-based combination. We included 38 patients. The primary endpoint was the bone response according bone metastasis location, spinal column, long bone, sacrum. There are no difference no difference of disease control rate according bone metastasis location. A better response was observed with patients who had less than 5 bone metastases. To conclude, the bone response is the same with according the bone metastasis location. I'm sorry, so stressed. Thank you.
Merci beaucoup, c'est parfait. And lastly, we want Dr. Chanley to tell us about the Carini study post-hoc analysis, please.
Thank you for the organisers to give us the opportunity to present our work. So Carino was a real-world UK-based study of 281 patients with advanced renal cell cancer. Patients had all previously received first-line IO doublet or IO-TKI and had then received second-line therapies. In this study, the duration of the first-line treatment was shorter for patients who had received first-line doublets compared to those who'd had first-line IO-TKI. The objective of this post-hoc analysis was to assess whether this finding reflects differences in patients' demographics, disease characteristics, and treatment response between these subgroups. We found that disease characteristics at diagnosis, including IMDC prognostic risk and disease stage, were generally similar between the two groups. However, there were some numerical differences between the groups. For example, a numerically larger proportion of the first-line IO doublet group compared to the IO-TKI group had IMDC intermediate or poor risk, and also a larger number of patients had stage 4 disease. The observation that median time to treatment discontinuation for first-line IO doublet was shorter than IO-TKI may reflect differences in adverse event rates or treatment effectiveness, or patients who receive first-line IO doublets may have had more aggressive disease and worse treatment responses. Median times to treatment discontinuation for second-line therapies, including cabozantinib, were numerically longer after IO doublets compared to IO-TKI. This analysis also showed that patients who may have experienced a poor response to first-line IO doublet did go on to make encouraging responses to second-line therapies, including cabozantinib. Please come and have a look at our poster to find out more.
Thank you so much. It was brilliant presented, and you were all on time, so that's really perfect. So thank you so much. And I just want to remember that there is a post-tour this late afternoon, so please join Michael and company and go and have a look on all these magnificent posters. I'll close the session. Thanks so much, and pass it for the next session. Olga, please.